healthcare data innovation with the Health Data Forum. Welcome to the Health Data Forum's YouTube channel, your gateway to thought-provoking conversations, cutting-edge insights, and groundbreaking advancements in healthcare data. Join us as we explore the transformative power of data to revolutionize healthcare delivery, patient care, and societal well-being. Embark on a journey of discovery. Delve into healthcare data through our informative videos, featuring leading experts, thought leaders, and innovators. Discover how our global movement, Data First, AI Later, is building a strong foundation for ethical and impactful healthcare solutions. Experience the collaborative spirit. Be a part of our vibrant community of health data enthusiasts, where ideas converge, partnerships flourish, and innovation takes center stage. Participate in discussions, share your perspectives, and join us in shaping the future of data-driven healthcare. Stay informed about the latest developments in healthcare data through our comprehensive video library. Catch up on insightful interviews, thought-provoking presentations, and engaging discussions about the role of data as the backbone of healthcare transformation. Join us in shaping the future of healthcare. Let's harness the power of data to transform healthcare for the better. Subscribe to our channel today and become part of the Health Data Forum's mission and our Data First, AI Later initiative to make healthcare data work for everyone.
Citizens in order to provide better health care and better interventions to promote their health. There should be some kind of, let me pull the topic to my field, public health information system that could gather all this information and that could link between healthcare providers, researchers, political deciders, that we can all see the benefits and the important effect that real-world data can have in every one of our aspects.
Ladies and gentlemen, thank you so much for joining the last session of day one. It's been an extremely long day. It's not over yet. We are going to have here the session 4 is going to be a session that is going to start the second part of the afternoon. And I'm so pleased to introduce Professor Rhidian Hurle as our chair for today. Chief Clinical Information Officer of NHS Wales. Professor Rhidian has a long background in research and also as a medical doctor and a surgeon. He keeps his practice active. Rhidian, thank you so much for joining, and the floor is all yours. A round of applause.
Afternoon, and thank you very much. I'm always impressed that people can moderate in a language which isn't their first language. So it'll be embarrassing that I will be moderating in my first language this afternoon. I will try and keep us to time. We have some excellent expertise who are going to give us a diverse range of opinions, and then we'll have a Q&A. I thought I'd start really by setting the scene that you can define health policy in many different ways, but one simple definition would be health policy can be defined as decisions, plans and actions that are undertaken to achieve specific healthcare goals within a society. So specific goals and outcomes is what we're interested in. I'll invite colleagues to come up, they'll present and then sit down. That way they won't get neck ache and they'll be able to see colleagues' presentations. So I'll ask them to come up in the order that they're seated, if that'll be all we actually will have. No, I'm joking, don't worry. I already told them the order. We'll have nearest to home first. If you'd like to introduce yourself and give a presentation. Thank you.
Hello, everyone. My name is Duarte Brito. I'm a public health doctor, currently working in Cascais in ULS Lisboa Ocidental, which is a Western Lisbon local health unit. And I'm just waiting for the presentation, but to just give you a context. This week, we presented in Cascais, we presented the health profile this Monday. So it's a really fresh outcome that I want to show to you. And I was just looking at my phone, and exactly in this place, like 1.5 years ago, we made here an event with health professionals from Cascais, where we kick-started this project. So we share with them what we were going to do. We asked them their feedback, and this is the result of that work. So basically, we have developed in Western Lisbon local health unit. We developed this Cascais health profile, which you can scan and access online. And this is included within a public health planning that this is just the first part. This health profile represents the diagnosis. So if we don't do the right diagnosis, if we don't get the right data, if we don't get the right questions, we are not going to be able to define, as we were speaking, the right objectives, to achieve the right goals, to achieve the aims that we want to concrete. And the end goal here is also to develop a local health plan, which is based on the information we gather during this diagnosis phase. And one of our outputs was actually a dashboard that is available publicly for everyone in Cascais, from the community to health professionals. So municipalities, parish can simply navigate in all this information, where you have demographic data, you have social economic data, you can drill down, you have some filters where you can choose if you want to know information about Cascais, about specific areas in Cascais. And actually, this is one of I think, the most relevant areas that we have, which is the analysis of mortality data. And for the ones who don't know, Portugal has a really, really strong mortality data. And this is basically the number of people who die by cause, by age and sex from the last 30 years, in Cascais. And we have this for all municipalities in Portugal. And basically what we did was to pick up And this is freely available data, so you could do the same thing as I did. And we just gathered this data, we analyzed it, we converted it to a visual aspect that people could easily navigate there. And basically, people, researchers, anyone can look for the information, if you are doing a research on cardiovascular disease, you can go there and search for the mortality in Cascais. Also, this is one of the really interesting outputs, that is stakeholder mapping in Cascais, which we did from different sources, also with the help of the municipality, of course. And doctors, people who want to find resources in the community can go here, search, and access all the resources that they have in Cascais. Of course, this is never totally updated, but we count with the community to keep it updated as long as we can. And actually, I also wanted to mention, I'm not going to dive in on the dashboard. You are free to explore it, but I just want to dive into specific data that we have found. And this is the relevance of not just looking for the municipality data, not just looking for the big picture, but also to drill down, because this is the nationality among foreigners. So it's kind of between 10 and 20% foreigners in Cascais. And you see the differences between different parishes in Cascais. And it's really different. You have on the right side, you have the parishes above the highway, and on the left, you have the parishes below the highway. So these are really, really great differences. As you can see, that in one way, you have a lot of people from African countries. On the other side, you have people from European countries. And this can affect real world interventions, public health interventions. Also, another relevant topic in Cascais and in Portugal right now, it's housing. And actually, we can see that the price of houses in Cascais is really high comparing to the rest of the country. So the light blue line is Cascais. But when we see the pink ones, you see the difference between the different parishes in Cascais. So you can actually see that not every place is the same. And this also impacts on people living there, on people looking for housing. And I can assure you that the feedback on this kind of information is that it makes health information, public health information, interesting. And many people already provide this feedback, from health professionals to stakeholders. And this is actually bringing the information to the public and to decision makers publicly available. And as I mentioned, one relevant topic is the community resource mapping that we did, more than 800 entities. And this is actually the basis for social prescription. And we are starting this project, so this is a really great timing. Less than 1 month ago, this project was kicked off in Cascais. And the mapping that it's already available, it's a really, really good support for this kind of interventions. And last messages, of course, we got a lot of feedback. We did a lot of interactions. We didn't start this project from scratch. So first we gathered health professionals' feedback. We have a great team, almost 20% from public health professionals to health professionals that are not within public health. We gather feedback from them. Then we had some meetings with municipalities, with stakeholders, with the social sector, with Cascais Hospital also. And we gathered that feedback. And then we went again through another round where we gathered more than 1,000 contributions to prioritize what should be the areas we should focus on public health until 2030. Of course, there's always room for automation. I can tell you that this is not an automated process, but it's easily automated. So we started from a low resource perspective, but actually we know that this is easily automated, and this is one of the things we want to develop on the next year. Of course, there's another topic right now, a hot topic in Portugal, which is risk stratification in the population, and is also an information that we can add up to this health profile. And the good thing is that like some years ago, this was used to be a PDF, so a static profile. And actually, since we have a dynamic profile, we can update the information from year to year, from month to month, depending on the resources we have available. And of course, we can always scale up this project. And I'm really glad that on the last Monday, there were already 3 public health units that were in our presentation, some meters from here. And so this is really a hot topic right now in Portugal. Public health is leading the process, is coordinating these kind of projects, not closed on health services, but within the community, with a lot of relation with stakeholders, with municipalities, and this is the way to go in related with health planning. But I think one of the message I want to leave is that we are discussing data, but we are discussing indicators, but in the end, our aim is to improve people's life. And we need to be really aware of that, not to just focus on data, but to translate that into real world impact and real world interventions. Thank you.
All right. Excellent start, I would say. I think starting with getting the diagnosis right, using the data is a absolutely noble aim, and designing for feedback from the start again is something that all of us should consider. Okay, my next guest is going to come up now, Daniel.
Hello. So thank you very much for the invitation here. My name's Daniel Morales. I'm a senior clinical epidemiologist based at the European Medicines Agency. Well, whilst we wait for the slides, I will make a start. So I'm here to give you a regulatory perspective of how we can use real-world evidence to shape policy decision-making. So I think the first thing to consider before we talk about real-world evidence is the EU regulatory network vision for how clinical evidence should be generated in itself. The vision is very much that all clinical evidence should be planned in advance, and it should have a very specific purpose. The research questions should be very clearly defined to inform the choice of study design and therefore the method of analysis that would be used. Whilst clinical trials remain the core for generating clinical evidence, they should be smarter, they should be better, and they should be faster. And that real-world evidence should be enabled and its value established. And at the center of all this should be the patient voice. Now, there are 3 broad areas for how real-world evidence may be used to inform regulatory decision-making. The first is on understanding, sorry, it's a bit of a distraction there. The first is on understanding clinical management. So these are things like disease epidemiological studies, also examining drug utilization. The second is on understanding the validity and also helping the planning of clinical evidence generation, such as in clinical trials, and understanding the representativeness as well. So I'll just move on. And the third area is one of causal inference, and also in the area of safety and also effectiveness, but also for understanding the impact of regulatory decision makings on public health. So the EMA has 3 pathways for generating real-world evidence. The first is the analysis of in-house databases. It has 2 primary care databases, data from Germany and also for the UK. The second are through tender framework contracts with academic consortia. These tend to be quite large projects that maybe take quite a bit of time and require quite bespoke access to either data or expertise that isn't always routinely available. And then lastly, what we have is the Darwin EU network, which I'll tell you a little bit more about now, and what you've also heard about earlier on during the day. So Darwin EU is the EU's network of data and expertise. Colleagues at the EMA work quite closely with those at the Coordination Centre, which is based at Erasmus MC, to assess study feasibility, develop protocols, and also support phenotyping as well. The Coordination Centre then produces an analytical package, which is sent to the different data partners that have been selected as being fit for purpose for a certain study. They execute the package on data held locally, and the data is transformed into the OMOP Common Data Model to support interoperability. The results are then sent back to the Coordination Centre, and a clinical report is written. The important advantage of using the Common Data Model in this time is that standardized analytics and tools can be implemented. Currently, there are around 20 data partners that are onboarded to Darwin EU, and we should have another 10 this year announced shortly, and with the aim to scale this up to 40 by the end of year 4. And we're currently in year 3 at the moment. This covers more than 130 million active patients, and the type of data are quite varied. Some are primary care data sources, others are secondary or hospital data sources. Some are electronic health records, others administrative claims data. There are registries, and there are also biobanks as well to support some pharmacogenomic studies. And we can see that the distribution here on the map of Europe. And as we've heard earlier on in the day, we know that there's a skew. But as we're scaling up and as new data becomes available, we're looking to very much to fill these gaps so we have a representative and generalizable population across Europe. EMA is very active in supporting real-world evidence generation. Over a one-year period from February 2023, 60 research topics were suggested for study, of which 47 were deemed feasible. And they were conducted through a number of different routes, as we've described, through either in-house studies, through the Darwin EU network, or through the framework contracts. Already since February of this year, we've had a similar numbers coming in, and we expect demand only to increase as we go forward. The requesters of the real-world evidence to support the decision-making was not surprising that most of them come from EMA committees. The most common one is PRAC, which is the committee responsible for monitoring the safety of medicines post-approval. The next most common was the PDCO, which is our pediatric committee. However, you can see from the distribution that all committees have had some interaction or engagement with real-world evidence. And the frequency really highlights I suppose, where real-world evidence is currently enabled within that decision-making process. And we see that PRAC and the safety post-approval area, real-world evidence has historically a much more established traditional value, and it's been used very well. However, these are research topics that have been requested, and it's normal to expect that perhaps not all studies can be feasible, and there are different reasons for the lack of feasibility. If we take, for example, our second most frequent requester from the pediatric committee, many of the studies were not feasible because they required very specific analysis of data, such as cancer tumor tissue biomarkers within a short time frame, and that's just not available to us. The studies that were done tend to be more about informing extrapolation between adults and children. The type of studies are most frequently done are drug utilization studies and studies focusing in the area of safety. We're also doing quite a lot of disease epidemiology studies and also analyses to support this feasibility or a design of other applicant studies as well. Have done studies looking at the effectiveness more in the area of vaccines, and also impact. But we expect this broad area and frequency to increase, and we are seeing that already. In terms of the therapeutic areas that are being most targeted, well, in that year, anti-cancer and immunomodulatory agents were most frequently the topic of the research question. And then secondly, anti-infectives. But we could see that this distribution is across many of the different therapeutic areas, and it merely reflects the trends in the dossiers that are being assessed at the regulators during that time. So if we move now to an example of how real-world evidence has been used to inform decision-making, first one I want to talk about is a Darwin EU study looking at treatment patterns in children with systemic lupus erythematosus. This was conducted to support, provide background information to support the review of a pediatric investigation plan. It was also used to assess treatment similarity between adults and children, thereby helping to inform extrapolation. And also the information is potentially useful for the planning of any clinical trials that may be required in children, or at least their feasibility. A second example is one in the area of safety, looking at this risk of suicidal ideation associated with GLP-1 receptor agonists. These are commonly used medicines for the treatment of type 2 diabetes and also for obesity, and safety concerns led to a review by the EMA PRAC committee following reports of suicidal ideation and self-injury. As part of this assessment and review, real-world evidence was used in a variety of ways. First of all, published literature of non-interventional studies was assessed. For example, there was a study published in the US looking at the risk of suicidal thoughts and found no association. And secondly, from a European perspective, we conducted a study using the in-house databases, which also demonstrated no causal association. This is just a summary of that study. It was an active comparator cohort study using another medicine for type 2 diabetes as the control. And what we see in an crude or unadjusted analysis, there does appear to be association. But when you use the granular data within the real-world data sources that we have, we can appropriately adjust for confounding, and that association becomes non-significant. This study, along with all the other studies and all the other evidence, led PRAC to conclude that the evidence or the reports coming in did not support a causal association. And I think a key point here is to distinguish what is the single bit of evidence you're looking at versus how do we use real-world evidence as part of the totality of evidence that can include preclinical studies, clinical trials, post-marketing surveillance, and also the real-world evidence itself. So whilst regulatory network is obviously the key stakeholder for many of the studies requests coming in, we do work with other stakeholders as well, including HTA bodies and payers. And we've done 2 studies in this area. One is to characterize patients with multiple myeloma, their treatments and survival. And the second study is one to look at overall survival in patients with non-small cell lung cancer prescribed different immunotherapies as first line. Both of those studies are done through Darwin EU. And discussions with HTA and payers are also continuing as well. So in summary, I think the demand for real-world evidence is only increasing, and therefore there are still gaps in the accessibility of real-world data, particularly to answer some questions, but also for the representativeness of different populations across the EU and beyond. The use of real-world evidence is being enabled, and it is slowly being established in the different areas. In some areas, it's already pretty well established, and in others, further work is required. But I think over time, we'll certainly get there. And I think initiatives like the EHDS will really help drive some of this forward. Thank you very much.
Thank you, Daniel. I thought there were some real clear messages there, and you started with clear, well-defined objectives. And the statement that you said, real-world evidence should be used as part of the totality of evidence is really resounding. Okay, our next guest, Emma, if you come up to the stage and please introduce yourself, and your presentation hopefully is loaded, and then we have one colleague who's online who'll go last.
Thank you very much. Good afternoon. Thank you very much for the kind invitation to be here today and present about real-world evidence, its impact on policy, and how community pharmacies have been contributing to this as well. So my name is Ema Paulino. I'm president of the National Pharmacies Association, which is the organization in Portugal that represents community pharmacy owners. I'm a pharmacist myself. So just to put the presentation into context, just a little bit of information about community pharmacy network in Portugal. We actually generate real-world data on a daily basis. I will explain how. But in terms of the network, we are over 2,900 pharmacies in Portugal that evenly distributed throughout the territory. We have demographic and geographic criteria for the establishment of pharmacies. Like I said, we cover the whole territory. So as for data collection tools and databases, as I've mentioned, the community pharmacy network in Portugal collects data on a regular basis, on a daily basis. We collect data from primary sources, so directly from patients through observation and measurements that we conduct in the community pharmacy premises, through self-reporting by patients themselves when we are collecting data for a specific project or for a specific objective. And we also collect data via questionnaires, which we conduct either in person or by phone or video conferencing. Then we have secondary sources, and I'm sorry for the typo there, but basically this is the data that we collect on a daily basis. We have databases that collect dispensing and prescribing data on a daily basis. We also have electronic medical records that we have access to, and we also add information in each community pharmacy. We also use population statistic databases as well as public reports and health plans, which we use then to combine and produce evidence based on also the data that we collect. So, as I've mentioned, our software tool, which is in place in most community pharmacies in Portugal, already allows us to collect data, specifically data that we aim to collect for a specific project or for a specific objective. And we can essentially put that questionnaire, feed that questionnaire into the software. And for instance, when a certain medication is dispensed, a pop-up comes up in the software system with a specific questionnaire, and the pharmacist is able to collect the information based on an interview with the patient, for instance. So nowadays, before we used to collect all this data via paper or online forms. Now this is fully integrated into our software system. And what does this combined data allow us to do? As I've mentioned, we also collect data on a daily basis on dispensing. And when I'm talking about dispensing, I'm not only talking about dispensing medicines, but also healthcare products and services in community pharmacies. So here, what you can see is a dashboard that we update on a daily basis on the number of vaccines that are being dispensed in each municipality in Portugal. Apart from the number of vaccines that we dispense, we are also able to get data on the number of vaccines that have been administered. And we are also able to calculate, based on the population that we know is eligible for vaccination in each municipality, the coverage of that we already have, the vaccine coverage for each municipality. So this is one of the examples. Another example, we also collect, for instance, information about shortages of medicines in community pharmacies. So based on what is reported as a medication shortage, we are able to monitor if the situation is getting better or worse, and we are able to interact with the public authorities in order to enhance certain activities or certain plans to mitigate the effect of shortages of medicines. And we are also able to understand whereas there's a specific medicine, a specific active substance or a specific therapeutic group that is being more affected than others, for us to have a targeted intervention for that specific group of medications. This is another example of how we have also produced evidence that eventually introduced new legislation in Portugal. For a number of years now, community pharmacies in Portugal have been dispensing specialty medicines that are usually only dispensed in hospital pharmacies. But we have been dispensing this medication in several pilot programs, and one of the bigger ones was put in place for the pandemic, where we were telling patients not to go to the hospital. So there was a quick consortium that was formed between different stakeholders, and a system was implemented for more patients to be able to access their hospital medicines via their community pharmacy. So we produced evidence based on the interventions that were done in community pharmacies. We also were able to calculate waiting times. We were able to calculate adherence measurements. We were also able to calculate the economic impact on families based on the kilometers that were saved for people who didn't have to go so far to get their medication. And all of this was presented. We had evidence that was published internationally. And finally, we have a new decree law that establishes that these medication can be dispensed in community pharmacy based on the evidence that the healthcare outcomes were not worse than what they were when medicines were being dispensed in hospital pharmacies. Another interesting study that we did, also based on data that we collected through community pharmacies, was the COVID-19 antigen testing policy that was implemented during the COVID pandemic, whereby the community pharmacy network was added to the clinical laboratory network to be able to provide antigen testing to the population. And what we did was we calculated the distances from where people lived to the nearest testing center. And what we were able to calculate was that we used the Gini coefficient to establish asymmetries in access, and we diminished these asymmetries and inequalities in access to testing, particularly for the people that were in less densely populated areas, the poorer, and also those that were more aged, so the elderly population. And this was also based on the information that we had on the number of tests that were done in community pharmacies and the calculations that we made in terms of the distances that people had to go to have access to a test. We also calculated these asymmetries based on operating hours and also the availability of the healthcare professional to perform the test. This is another interesting example of how we are already working with some ULS structures in Portugal, and also with some private hospitals to be able to help prepare for increased pressure in emergency care rooms. So what we do, we collect data on the dispensing of non-prescription medicines for flu-like symptoms in community pharmacies. And so via collection of this data, we are able to anticipate in 2 weeks when the peak of the emergency room search will be. So this allows emergency room teams and hospital administrators to plan for a peak of search of services in their hospitals or even in primary care. We do this on a weekly basis, so this database is available, freely available. It's a dashboard. It can be consulted for each municipality. We do it for the whole territory, but it is we are able to filter for each municipality. And obviously, this was done based on the calculation of on a design of an algorithm that took into account previous seasonal flu peaks, etc., to refine the model so that now we have a better model that can predict this kind of peaks for the system. And finally, we have also used data. We can also use data not only to identify, work on aggregated data that can help us, for instance, prepare for peak searches for emergency room services, but we can also go on the basis of the individual and help individuals in their healthcare journey. So in this case, for instance, we are able to, based on the history of medicine taking by a certain individual, when we interact with the person, for instance, who is going to start a new medication, we are able to predict if that person will be adherent and persistent to the therapy or not. And based on that information that we have in our software system, we are able to personalize our intervention and actually also plan to follow up on that patient, particularly when that person is known to have given up on the new medication, for instance, or when something has to occur, such as a change in dose or a switch in medication. So not only is data, aggregated data, able to help us in our policies and our organization in terms of the system, but we are also able to use the data to influence our interventions at the personal level, at the individual level. What are the opportunities for community pharmacy to generate real-world evidence? I've brought to you some examples. We want to innovate. We have access to a lot of data, and we can do a lot with this data if it is also integrated with other data that is being collected. And for instance, this information from Cascais that we've just seen, we can definitely do some cross comparisons that can be interesting to assess whether certain policies or certain interventions are being effective. We want to establish new partnerships to improve the quality of service, and we use this data also for training purposes, to redefine guidelines, to elaborate on standard procedures, etc. We generate evidence of high quality and impact. We have a history of publishing data in international peer-reviewed journals, which we think is good practice. And obviously, we also use data to advocate for community pharmacies to broaden their scope of action as healthcare providers. The data, for instance, that we gathered from our intervention in the COVID-19 testing allowed us to now be integrated in full integration and full cooperation with healthcare centers, vaccinating the population for flu and for COVID-19 also, because it was shown that community pharmacies are very accessible. The healthcare professionals are prepared. People have trust in community pharmacy services. So policies that include community pharmacies have a high degree of success. So I just brought finally a quote from John Adams, president of the USA, some years ago. Facts are stubborn things, and whatever may be our wishes, our inclinations, or the dictates of our passions, they cannot alter the state of facts and evidence. And hopefully this will remain as such. Thank you.
Well, thank you. I hope you'd agree that was quite impressive, the use of data collected by a very strong professional network, which is across the whole of the country. And I think there's some lessons learned. I'm going to take some home, actually, to our chief pharmacist about some of the things you're doing there. That's very good. Right. While we get the video up for Doreen to come in, I will warn my fellow compatriots on stage that I'll have a couple of questions relating to your presentation, and I'll also take some from the floor, and then we'll have some general questions about what's going on. Okay, can you...
Okay, so this presentation is going to be a bit different from the ones that you've heard. It's less about the science, and it's going to be presenting a consortia or alliance that we have within the UK. And the purposes for this, for me, is really because we have a lot of interesting working groups within the alliance that I think that have potential to expand their international collaborations, learning from international, but also fostering learning from the UK. So I am the head of the alliance. We have a small secretariat that coordinates the different working groups. So I'm going to be presenting on behalf of the working group. So I'm not purporting to be a subject matter specialist for some of the work, the excellent work that the Alliance does. So the Alliance is a leading consortia of health care and research organizations that have come together to establish best practice around the ethical use of health data for research and innovation at scale. And it started off really small, influential organizations, about 9 founding members. But within the last 5 years, we have grown to 107 members, and we've also diversified our membership. Initially, it was organizations that held data, so data custodians, but we can see that now it has different organizations, from regulatory bodies, trade bodies. We have charities. We also have academics as well represented. So a very diverse alliance. And the alliance is focused on 3 main things. So what we're trying to achieve, first of all, is to ensure that we shape standards. So we agree on best practice. We then co-develop standards. We publish recommendations, and then we share resources to basically help with the adoption of those recommendations. So within the adoption stage, we support the organizations through adoption. We are conveners, so we facilitate implementation as well. And in cases where it's needed, we also incentivize the change, such as running funding calls to make sure that the best practice standards are adopted across the health ecosystem. So we also build communities, as I said, with our convening role, and we make sure that we share knowledge, we reduce duplication across the sector, and that we align strategies and plans. So in terms of the communities that have been convened, we have the trust and transparency community, and that looks mostly at information governance processes. We have a UK-wide pan-UK data governance steering group and action forces that focuses on aligning data governance across the different actors of the UK health data system. We also have the Public Engagement and Data Research Initiative called PEDRI, and that furthers best practices when we're looking at engaging and working with the public within data research, both within the research, but also the information governance and the technological developments as well. And then we also have a researcher registry and information governance and policy working group. And this is looking at streamlining processes and basically creating a researcher passport so that researchers have easier access to data, but that this is done in a safe and secure way by trusted researchers. Then we have a data standards group that's most closely aligned with the theme of this workshop. And this as a data officers group that looks to foster best practices amongst those that are data officers in the sector. And then we also have the Observational Medical Outcomes Partnership, OMOP, and I see that that's come up in different talks as well, a special interest group around this. And then we also have Diversity in Data Special Interest Group. And the diversity in data is very much looking at ensuring that the data that we have is representative so that the outcomes that we have are not applicable only to a certain generalized population, but apply across a representative sample of the UK. So we have had a white paper that's been recently published within this space with recommendations for how to improve the diversity, ethnic diversity, especially in data. We also have the clinical trials, key stakeholder prioritization forum falling under the data standards. Then the third sector is technology services. And under here, we have a co-development with partners of an enhanced gateway that collates metadata and acts as a resource for people to find out additional information about the data that's deposited. And Alliance members are committed to depositing their data sets within the gateway. So the gateway has recently relaunched, and it's a great resource. We also contribute to various communities that are convened by Data and Analytics Research Environment UK, they're UK, and they are a data agnostic organization that are looking at methods to federate data across the UK. And finally, we work with the Health Data Research UK's capacity building team that look into elements such as the Black Internship Programme. We recognize that African Caribbean people in the UK are severely underrepresented within the data space, not from a patient perspective, but from a technical perspective and research perspective. So we support a program that places them across the ecosystem in different roles within data science. And then we also support the development of new training and resources on the HDR UK Futures platform. I also wanted to highlight, as I said, that we have ongoing international work, which I'll highlight in a future slide. And part of this is carried out under the Quantum EU Horizon program. And these slides will be shared, so I'll leave you to read those at a later date, but I will highlight some of the work that we're taking forward at an international level. So I wanted to highlight that we have standards that we've developed that are being applied across the UK. Some of the notable ones are, as I said, the enhancing diversity in data work. These are the standards, but there's a white paper that's been developed. Also improving transparency in the use of data for research. This has had a lot of traction, and it's one of the areas that we incentivized with a funding call so that organizations could create new tools, improve their websites, and make the whole process more transparent for the public audience so that people could see what is being done with their data. We also make sure in terms of pushing for adoption that we survey the uptake of the standards in terms of practice. So we did this with the OMOP common data model and looking at the adoption of this across the UK, which is the third image there. So what's the impact of all this work been? I wanted to highlight a number of things. So the first impact is the acceleration of data discovery and access. So January 2020 saw the launch of the gateway that I mentioned, which is a portal for data discovery and access. And this was a platform for Alliance members to implement the FAIR guiding principles, which of findability and accessibility, to make sure that data sets could be found. We also have the 5 Safes form. So this was created in 2020 when we had the emergence of COVID-19. There was a real need for researchers to access priority data sets quickly and effectively. So this was the reason for the gateway. So the Alliance worked with the National Trusted Research Environments delivery partners to develop a harmonized data access form based on the 5 Safes. This was subsequently embedded into the gateway and used by researchers to access those priority data sets. So this work is now being taken forward by the Pan-UK Data Steering Group that I mentioned. So we also work to shape policy and best practice for trusted research environments. There's a landmark paper of the Alliance around the trusted research environments, published in December 2020, which outlines the principles and best practice for data sharing and linkage within TREs. It was led by Professor Tim Hubbard, who is now the director of Elixir and is the most viewed, downloaded, and cited paper. Alongside the Goldacre review, it definitely informed data access policy within the National Health Service in England and investment in its secure data environments. So practice is also changing in Europe, where the joint action towards European health data space is helping to promote these concepts and principles. And also I wanted to highlight the European Network of Trusted Research Environments in Trust, which was launched earlier this year and aims to create a network of TREs for assessing sensitive data. And HTR UK is one of the project partners and leading a work package on outreach, policy, and dissemination under this. And then I wanted to highlight from standards on paper to standardized analytics and looking at our work on OMOP, especially here. So we've been embracing international standards. We don't only create them for the UK. And we facilitate adoption of existing and recognized standards, such as the OMOP Common Data Model developed by Odyssey, the Observational Health Data Sciences Informatics, which was a key recommendation of the Data Standards White Paper that was published back in 2021. So to support data interoperability in the UK, at the end of 2022, the Alliance collaborated with the European Health Data Evidence Network, or EDEN, to fund 5 UK data partners and map their data sets to OMOP. So an Alliance special interest group on OMOP was established as a platform to share knowledge and experience and resources to transform OMOP, for transformation to OMOP. So we've seen the influence on national policy, and there has been commitment by the National Health Service in England to adopt the OMOP within their secure data environments across all the regions in England. And most recently, we've also established the Real World Evidence Network to demonstrate the potential of OMOP, the CDM, as an enabler of cross-nation research studies. And under this, we have 7 data partners. So I wanted to highlight, as I said, the capacity building work and the Black Internship Program that we have. You can see that there is growth and ever-increasing demand from the community, and also increasing number of organizations that take on our interns. Finally, I wanted to highlight some of the public involvement and engagement work that we do. So we have strong commitment to public involvement and engagement. And we just wanted to highlight, for example, the fact that we have the public voice represented at the most senior level of the Alliance governance, where we have 2 public members who sit with the executive committee. And last year, we also extended membership to non-data custodians and also included the very influential public organizations that are focused on making sure that the public are involved in data research. And we also developed a partnership with Petri. This is not to be confused with the Spanish footballer. I think you might be more familiar with the name under that guise, but this is a sector-wide partnership that is data agnostic and brings in the key players across the UK and makes sure that we're furthering best practice around engagement. It's aiming to drive alignment in good practice, and we worked with Pedri to deliver 3 workshops that aimed to embed and to develop best practice standards around engagement. And we're currently supporting development of a public engagement hub for useful resources in data and statistics. So I will probably stop here, but just to highlight as well a really useful partnership that we have with Health Data Research UK and their Public Advisory Board, who co-produce the standards with us so that we ensure that the public voice is embedded in everything that we do. Thank you.
Okay, thank you very much, Doreen. Okay, Barbara, would you like to come up onto stage? So what we'll do now is, oh, by the way, I had a quick look to check online, and Wales is part of the HDR UK. It's one of the university in Cardiff University, so I was pleased to see that we are partnering. There's often confusion in the UK when they talk about the NHS. The NHS is England, and there's an NHS in Scotland, and there's an NHS in Wales. So it often causes a bit of confusion. Okay, so if we could start with, I'll just go through the presentations while we're finding some online questions. And let's start with our first presentation. I thought there were some really key messages there about how you help policy decision at a local level using local data. And the question that I wanted to know is, how complete do you believe your data set is? And are there bits that are missing, and how are you going to get them if they are missing? In other words, are there people resistant to giving you data because you might expose it in a public forum?
Actually, I didn't mention it in detail, but most of the dashboard is actually from secondary data. So that is collected annually and every 10 years in Portugal. So we have really specific data that is collected every 10 years. But also annually, for example, mortality data. So we actually didn't went through the data from of people needed to comply or needed to give their permission to, because it's already given when they attend the health services. So they already, we already discussed that on the previous session. But we also have medical appointments, the reason why people go to the doctor, and but we did an anonymization process on that specific data. And I didn't mention, but we actually asked for a data protection audit on our own request, and so based on their advices, we actually removed some of the data we wanted to share. So right now, all the data that we are sharing, it's publicly available. And yeah, so we don't have that problem actually. And I think that's also a really key point to ensure that people trust the data, because that data that is used on the dashboard, every one of you can get that except for the medical appointments. That's the only part of the dashboard that is not available. And you can get their data from people who are born in each specific parish every year. You have data from the housing prices every year.
In the interest of time, how complete, give me a percentage of how complete you believe your data set is to make informed health policy decisions. I'll bring in Barbara as well.
Okay. I would say maybe 60%, because I still believe it's room for improvement, but for specific decisions for health planning, I believe it's a really strong data set, because it includes both health services from the production side on medical appointments, etc. Also mortality, so health outcomes and outcomes, and also social determinants of health, which is always really difficult to express.
Yes, I particularly like the way you linked it to housing and regions. Have you any comments on that?
Yes, thank you for your question. Is very relevant for us, for the municipality, because we need to work together, integrated information, data, and with some strong evidence, with strong data, we can plan local policies, which is very important for us. For instance, we can integrate some clinical issues like overweight of people and relate to our, I don't know, maybe sports equipments, green spaces, and other local policies, and evaluate if you need to have more policies, more objective policies, if we need to do some new equipment, and only with integrated data we can plan and plan services and optimize resources. So
yeah, I think it was pretty obvious, wasn't it, to the audience, that you can look at demand management in a completely different way.
And we are working together.
Yeah, in partnership is very key. Could you just tell me, do you think it's influenced the funding that's going to particular areas? Because now you have data that is identifying perhaps need being greater in one area than another?
We are trying to geolocate these issues, like data from clinicians and data from our municipality. And we would like to integrate also pharmacy data to objectively plan resources, plan interventions, and to gain value and promote and prevent diseases, promote health, prevent diseases, which is our aim goal to the municipality.
Yeah, we'd absolutely agree with that. Okay, lovely. Thank you. Can we move on to Daniel? So the European Medicine Agency, the obvious question is that I'm going to ask you, does it include UK data?
It does.
Okay, that's good. We're pleased about that. I'm interested in the validity of the data. You mentioned that was important within the clinical context. How you are making sure that the data from the different partners across the different countries is of the same standard? What mechanisms are you employing to ensure the quality of the data that you're collecting from these areas?
Well, first of all, it's important to say, I think as in a previous session, that we always consider and look at the data as being fit for purpose. We know it's very heterogeneous. We know there are different methods of collection and completeness as well. But even with gaps, it can still be fit for purpose for the specific research question. As part of onboarding a data source to the Darwin EU network, it goes through quite a rigorous validation step. In some respects, there are many data quality metrics that are examined, covering all the different domains of data quality. And this is another plug for the EMA's data quality framework, which was published towards the end of last year as well. So I'd refer people to that if they want further information about it. And that way, if there are problems or issues identified, there's an opportunity to actually provide feedback and fix. Yeah. Some of that is before being used, and some of that can be what we find out during the conduct of a study. Something doesn't look right, for example, the OMUC transformation and the specific criteria, that could be fed back. So there are a lot of advantages for data partners being part of the network as well, because it constantly is an iterative process of improving the quality of data as we try to answer more and more questions.
Okay. What I was interested to see is you've got 20 data partners. I think you're trying to expand that. You were highlighting. You're currently looking at about 130 million patients. Do you have a particular figure of how many patients you think you need to have the power to draw these conclusions?
It's enough depending on the research question.
Okay.
There are some questions that not even maybe the European population by itself would be sufficient to do. And we have to then think potentially globally or meta-analyses of multiple evidence sources. But with the size of the population in Europe, it does offer many advantages and many of the questions that we can do. And I think generalizability and representativeness is really, really important. And within the regulatory system, whilst we know we can appraise and assess evidence from other parts of the world, there's always a heightened interest in understanding the data and the evidence from Europe.
Yeah, I may take the liberty of just asking about patient safety in terms of particularly with drug and interactions. You feel that there's real world evidence that is demonstrating things that perhaps haven't been identified in those traditional processes of bringing a medicine from the laboratory to the bedside?
Yes, absolutely. And that's been the cornerstone of often the use of real world evidence in the post-approval setting. Despite having sometimes quite large clinical trials, they're not large enough to detect many of the rare adverse effects that can really impact on patient well-being. So real world evidence in that sense is complementary to the pharmacovigilance activities that normally happen through spontaneous case reports and in the UK, the L card system, and other places like that.
Yeah, I'm glad you mentioned the yellow card system that actually originated in Cardiff with Professor Routledge, a colleague of mine, which takes us neatly over to pharmacy, doesn't it? A couple of things that I thought were interesting. That I never knew why the pharmacy sign outside is always green. But I think what we saw for you had some carbon saving objectives there by people not having to travel so far to get their medicines. So if I could just pick on a few things. One was about the software system. I was keen to know, I think I picked up the name Sapharma. Is that a single instance standardized software system across Portugal, or is it locally configured and therefore you have to do some data manipulation to work out what's going on?
Well, actually, Sapharma is in approximately 80% of community pharmacies in Portugal, which allows us to obviously collect representative data from the whole country. For certain studies, we also collect data from pharmacies using other software systems. But usually for the purposes that we need, the data that we already collect from pharmacies using the Sapharma is enough to calculate.
Okay, and does Portugal provide a commercial incentive to try and get everyone on the same platform?
This is provided free of charge from the National Pharmacies Association to pharmacies, so that's why the use level is so high.
No, that's a model that perhaps many of us can follow. One of the things that you talked about was real-time data and the ability to identify medicines shortages rather. I'm interested in whether you're using any of this data to influence your purchasing power for particular medications, particularly those that are high volume. Have you got any mechanisms where you can get a commercial advantage because you know how much you're using?
Well, we don't use that data at the National Pharmacy Association per se, because we are a non-profit, non-commercial organization. But groups of community pharmacies, they are able to access aggregated data, and they are able to use that data for their purchasing objectives. Also, the National Association of Pharmacies is the owner of a commercial company that does commercialize the data, but usually the data is, for instance, sold to the pharmaceutical industry for certain purposes, like understanding how a certain medicine behaves in the market, or how the quota is performing against other types of medications, not for purchasing issues. Those are more reserved to purchasing groups that have been formed for community pharmacies in Portugal, because in Portugal we still have restricted ownership for pharmacies, so every owner may only own up to 4 pharmacies. So there are virtual groups that have come up to aggregate a number of pharmacies to increase their purchasing power, well, as it relates to the pharmaceutical industry and other suppliers. That is not done by the National Pharmacy Association. That is done separately by these groups.
Well, you never know, you might influence policy to do that, to reduce the cost of some of your high volume drugs. Okay, we'll go back to online. Doreen, can you hear us? Great. Okay. I was interested in your presentation when you talked about the ethical use of data across your partnerships. Could you just explain to us the decision making regarding what is ethical and what isn't ethical? Is there a particular framework committee? How do you make ethical decisions?
I think it might be useful for me to clarify. So actually, can you hear me first of all?
Yes, we can hear you.
Yeah, okay. I think that might have been ethnicity rather than ethics. We do also handle ethics, but I think it'd be just useful for me to clarify which one.
Okay, so apologies if I misunderstood that. Let's go to the ethnicity issue about the ambition to remove bias in data sets because of lack of certain characteristics within the population being studied. Have you got any comments about how you've been able to engage with partners about that?
Yeah, there is a lot of interest. I think it's very clear to everybody that's practicing data science that it can do wonderful things, but if it's operating with incomplete data, and especially if there's a pattern in that incomplete data around certain ethnicities, then you end up producing interventions, medicines, etc., that are not fit for purpose for select members of the population. I think it was very evident in the COVID pandemic, for example, that some of the public health interventions that were created simply didn't work for certain ethnicities and certain communities. Yeah. So there is a lot of support around the ethnicity coding and making sure that it's complete, but also to actually encourage populations to be happy to share their ethnicity. We have a brilliant data scientist, Sarah Khalid, based at Oxford, and part of their campaign focused on working with communities that were not happy to disclose their ethnicity to actually change the narrative so that they actually were proud to claim their ethnicity.
Yeah, and I think it's very important, isn't it? Yeah, very important to encourage people because you need that data to get a real understanding. Okay. And you mentioned about standards and the development of standards. I always smile when we develop a standard. We rarely look at our wider than the country that we live to look if those standards have already been developed, and therefore we invent a standard. How are we in the UK engaging with our European partners on these standards?
Yeah, so before any standard work is done, we do scope what's already out there and see if it's actually fit for purpose for the UK. And if it is, then there is no point in reinventing the wheel. So we work with what's there and we work with our international partners. Where we need something that's very UK specific, as you were saying, we have a very interesting health system that's not only different from one nation to the other, but we have a lot of differences between the different providers of healthcare systems in the UK. So that often requires quite a lot of coordination, negotiation to work with existing standards to adapt them for the UK or to create new ones where there aren't any standards. So we're keen not to duplicate work.
Excellent. Okay, fine. So we've got a roaming microphone. It's Friday afternoon, so our online community are not asking questions now. So we rely on those within the audience to come up with any. And we've got a hand. We've got a hand. We're going to have, it's not an auction. We've got a hand, have we? We've got, yes. Okay. So the microphone's coming to you now.
I have a practical question. I work in primary care, child health care, and I see many children from other countries. So when I would encounter a child from Cascais, and the child has been to the pharmacy to be vaccinated, this child also has thalassemia, and I wanted to know if the child has had reactions on the first vaccinations like fever. How could I ideally retrieve these data in my public health data set in the Netherlands? This is in the Netherlands. The city is Almere, and it's a very multicultural city.
Okay. So
and this is Relive happening now.
Yeah, this is a question about
And they
data.
have a booklet in Portuguese. I do not read Portuguese.
It's a question of data sharing, isn't it?
And
yeah.
we use ATC, so I think we could use interoperable data.
Okay, so how's the pharmacy community share that data when they've given those vaccines?
Yes, so for the moment, we have an e-bulletin in Portugal, so it's an electronic vaccination bulletin. It is in, I think that it is only in Portuguese, and that is definitely an opportunity to improve. But it is digital, and all the vaccines that we administer in community pharmacy, they are registered in the same bulletin, and as well as the vaccines that are administered in the healthcare centers. So in community pharmacies, we are able to read and register the vaccine bulletin right now, the same as in healthcare centers. When we administrate the vaccine, all the information about who administered and when, which kind of vaccine, which arm, everything is registered. And also if we have identified an adverse drug reaction with a certain vaccine. So all the information is able to be fed into the e-bulletin. I do think that there is, like I mentioned, it is in Portuguese. And I remember that when I tried to show my yellow fever vaccine in the e-bulletin when I just went to South Africa, obviously they couldn't understand. So this is definitely something we have to work on. I don't know if there is an English version.
I think Daniel would like to make a comment.
So it's a very good question. We've talked a lot about the European health data space in the context of secondary use of health data. We shouldn't forget a key element is also to improve the primary use of health data. And one of the objectives of that is to identify and improve on that exact similar scenario of data sharing between member states. Yeah, my understanding. And
one of those key components, of course, is a demographic standard. Because if you can't identify the individual across the various contexts in which they're delivering care, you're going to run into trouble, aren't you? So as we come to close this up, I'm going to ask the same question to all of you. It's got a little bit of a sting in it, so take a deep breath and decide who's going to go first. Given that you're on your leadership journey in the various things that you're doing, what is it that you would have liked to have known that you know now at the start of your leadership journey and the delivery of your program? So what have you learned that you wish someone had told you at the very beginning of when you're trying to solve this problem? So while we have stunned silence, I'll go to my I'll go video first, shall I?
Let's wait a little bit. Reflection. I think
let's go video first.
I think Daniel is probably saying something, right?
I can say something, whether it's smart enough, I don't know. What would I have liked to have known? So I've been co-leading the UMA use case, Health Data EU pilot to inform the health EHDS learnings. That's been very informative. But it's been a slow process as well. And we're only now coming to pull together the EHDS and then to really start the implementation. I think if we'd have known some of the findings a little bit sooner, it may have speeded up the process as well.
Okay. How about you, Emma, with your pharmacy community?
Maybe I can use vaccination as an example. The way that we integrated the vaccination seasonal vaccination plan last year, it was actually in the end it worked quite well because the coverage was quite good both for flu and COVID-19 vaccines. Even for COVID-19, 5 times above the European average, which I think is pretty good. But there was some resistance from healthcare professionals in general, and those that were more traditionally involved in the seasonal vaccination. And I think that it's due to other reasons besides vaccine coverage. It's because in Portugal, some of the objectives that are linked to performance of institutions are linked to specific indicators that may move if there are new partnerships like this one. So I think that definitely when we start a new project, we have to understand all the implications, and we have to make sure that the incentives are put in the right place, and that if there are incentives for a certain individual or healthcare professional or institution to provide care as it always has, but something has to change in that process, then you have to move to change the incentive as well. Otherwise, it will face resistance. And I think that that is important for any new program or any new way of organizing whatever it is. First, you have to look at how the incentives are being given, what is the model to assess performance, and also take that into account when you are designing a program.
Yeah, very informative answer that. Doreen, would you like to come in?
Yeah, I have to say that's a very, very hard and fair question, but I will attempt to answer. My response is going to be quite ironic, because I think within the context of building alliances, I think the most important thing I've learned over the last couple of years as I've moved into more senior leadership position is actually the importance of making personal connections. And I think in the post-COVID world, a lot of us are online, hence the irony, because I'm online today. Unfortunately, I couldn't join you, is really the importance of speaking to people and spending time with people and building those connections, because often I think that's where the greatest collaborations happen. And I think that's really vital for, a partnership organization such as ours.
I think that's a very valid comment. It's very hard to develop social capital over video, isn't it? Yes, okay, thank you. And so we'll finish with our hosts, as it were.
Okay, when I started my functions, I knew that it was very difficult to have access to health data from NHS and to integrate that data with municipality data. So it was a challenge, and we managed to bring together those data. Why? Because data that Duarte presented are access for all. So it's very easy for us to integrate those data, like NHS data and municipality data. So I think it was the hardest thing to do when I first started, but now I'm very pleased that we are, facing the future with that.
Excellent. Okay, so as a chair of this session, all that remains for me is to thank the sponsors and for us to put our hands together in a traditional way to thank the panel. Thank you very much.
Thank you so much. Thank you.
Everybody's looking for a healthcare system they can trust. In the age of AI, transparency and ethical data practices are revolutionizing healthcare. By ensuring that data is handled with care, we build trust among patients, healthcare professionals, and stakeholders. Why does this matter? Ethical AI ensures that every decision made is aligned with human values, providing accountability and eliminating bias. This means better outcomes for everyone involved. But it's not just about technology, it's about trust. When patients know their data is safe and used ethically, they feel more confident and engaged in their healthcare journey. Let's embrace transparency and ethical data practices, because a trusted healthcare system is a better healthcare system. Transforming healthcare, one ethical step at a time.